Good afternoon, everyone. Welcome to this debate. Do please settle down and move to the front if you like. My name's Andrew Jack from the Financial Times. It's a great pleasure to moderate this discussion debate. Before I go into a little more detail, there's just a practical issue. It's actually just, could you put the slide back on for 1 sec, please? The other one. We are going to try and make this interactive. So there's an attempt to use your smartphones and to do a poll. So we're interested in getting your opinion of this question now at the start, and then again after we've heard from our two speakers for and against, and from you. So before or just at the end, we'll do a second vote, but it would be great to get your views now before you hear the arguments. So if you haven't already downloaded the app, if you've got a smartphone, then you can tap that one in and download it. If you have already downloaded the app, then you can go onto the menu to the surveys button towards the bottom, and there you will see live. The second option is Big Debate Poll 1. So scarce resources are best applied to prevention. So please, between now and 2 minutes' time, if you have time to download the app, if you haven't, and if you have, find that survey and tell us whether you're for or against the motion. Scarce resources are best applied to prevention. So thanks very much for all coming. So over the next hour, we're going to hear from two great speakers on this subject. They'll each do short presentations, and then we want to open it up to you. We might be able to try to structure it a little bit if there are a couple of themes that seem to kind of draw attention and take 2 or 3 blocks of questions around those themes. But really, the second half or the second 2/3 of this are over to you to hear your sharp, short, distilled perspective, please, on this debate, very important debate. It does indeed feel a bit like the US presidential debate here with these podium and speakers, but certainly the issues... He's moving already. Certainly the issue... We're not allowing any hectoring, though, from the stage. So the issue is certainly as important in many ways, but we'll try to keep it much more civilized. And I think certainly our two proponents here are much more credible, respectable, mainstream figures than perhaps we've seen in certain other countries at the moment. I don't know if people have started to vote yet. I don't know if we can even see any sort of running tally, if that's beginning to come up. But if not, please keep pressing the button for the first few minutes. Look, that's great. Okay, so, scarce resources are best provided to prevention. Okay, you better take that one off quickly. So
about as well as Donald Trump is doing.
But the doors are locked. You can't leave for the next hour. So let's move then to our debate. So scarce resources are best applied to prevention. And for the first opening presentation in favour of that argument, I'll call on Karen Canfell from New South Wales to talk. Karen.
Thanks, Andrew. And I certainly hope that at the end of my talk, we don't lose that 84% win in favour of prevention. So scarce resources are best applied to prevention. By 2030, 22 million people will be diagnosed with cancer every year. We're facing unprecedented challenges in the global burden of cancer over the next few decades. This burden's already immense, but if current trends continue, unfortunately a huge increase in the number of cases is expected due to growing and ageing populations, and also due to the increasing westernisation of lifestyles in low and middle income countries, and a consequent profound epidemiologic transition in the profiles of risk of cancer for many countries. What's more, unless current trends are disrupted, the largest increases in burden of disease will be in developing countries, further exacerbating existing major inequities. In high-income countries, about a 40% increase from 2008 to 2030 is expected, but in middle-income countries, an 80% increase is anticipated, and for the poorest countries, there'll be a doubling, 100% increase in the burden of cancer in just 20 years. At the same time, the global annual cost of cancer, including the cost of premature death and disability, has been estimated as well over $1 trillion, and this will continue to rise with increasing burden of disease. The American Cancer Society has commented that the silent pandemic of cancer is spreading through low and middle income countries, and that without a substantive global response, it could overwhelm public health systems, threaten social structures, and undermine economic development efforts. But it doesn't have to be this way. The right mix of cancer control investments now will minimise the future burden of disease. Of course, positioning our investment decisions as being black and white, either-or choices between prevention and treatment actually represents a false dichotomy. A more nuanced framing is that we need to better understand the optimal mix of investments. The questions that face us are, given that resources are limited, how should primary and secondary prevention strategies be prioritised against investments in better cancer treatments and investments into improving the survivorship experience? How can we ever deny the primacy of the need to provide adequate palliative care to all cancer sufferers? And finally, how might these decisions and priorities differ in low, middle, and high resource settings? Recently, the World Bank has considered just these questions and has defined a set of best buys for resource-limited settings. This essential cancer intervention package includes diagnosis and treatment for early breast cancer and for selected curable childhood cancers, and palliative care. But it places a very high priority on relatively affordable, cost-effective and feasible preventative interventions, including tobacco control, universal infant vaccination against hepatitis B, and school-based HPV vaccination and cervical screening initiatives. So why is prevention so crucial to any realistic package of interventions? Well, it's because prevention strategies are by far the most cost-effective approach to minimising the future burden of cancer. Every dollar spent on effective prevention will maximise the returns in terms of years of life saved and reduction in disability. So why is prevention so cost-effective? Well, in large part, it's because effective interventions that target the major causes of cancer will save the greatest number of lives. By far the most important of these risk factors still is tobacco. And although, as we know, tobacco consumption is declining in many high-income countries, the well-documented stages of the epidemic are now unfolding in many low and middle-income countries, with increasing or persistently high smoking rates, especially in men. And these patterns will be reflected in the expected major increases in tobacco-related deaths, tracking 2 to 3 decades later. The WHO Framework Convention on Tobacco Control was established 11 years ago, and WHO introduced a package of evidence-based tobacco control interventions known as Empower in 2008. Of these, increasing excise taxes on tobacco is one of the most effective and cost-effective measures of all. From 2007 to 2010, 41 countries adopted at least one highest level Empower policy, with 14 introducing excise taxes at the highest level. And this has been estimated to result in 15 million fewer smokers, which will avert an expected 7.4 premature deaths. 7.4 million. Some cancers are also amenable to secondary prevention with screening. For example, globally, more than 500,000 women are diagnosed with cervical cancer every year, and over 250,000 women die from it. Low and middle income countries carry 85% of this burden. This stark difference between high and low resource countries is due mainly and simply to differences in access to effective screening programs. The Pap smear, a simple test involving sampling of the cervical cells, has underpinned successful cervical screening programs in high-income countries around the world, where cancer incidence and mortality has plummeted by 50% or more. And recent advances will improve outcomes even further. The last decade's seen the emergence of evidence of several large-scale clinical trials on molecular testing for HPV, a highly sensitive method that screens for the virus that causes cervical cancer. A number of high-resource countries are now in transition to primary HPV screening, which will not only be more effective, but will save costs because better protection is achieved, even in the context of longer screening intervals. This is a win-win scenario for women, providers, and government. HPV screening has a critical role in low-income settings as well, as the technology becomes progressively more affordable and practical. Just a few weeks ago, the American Society for Clinical Oncology issued resource-stratified, evidence-based recommendations on the secondary prevention of cervical cancer globally, recommending that HPV screening is used even in low-resource settings. Just a few HPV screens in a lifetime can reduce a woman's lifetime risk of cervical cancer by up to a half. And of course, a critical breakthrough has involved the rollout of prophylactic vaccines against HPV. 75 countries have now implemented programs, with 47 females now fully vaccinated. In countries with high coverage, the effects are dramatic. In Australia, for example, the first country to introduce a national publicly funded vaccine program, rates of infection with the vaccine-included HPV types have plummeted by over 70% in young women. Rates of anogenital warts caused by other HPV types included in the vaccine have also fallen by over 70%. And most excitingly of all, we're now seeing very substantial reductions in precancerous cervical abnormalities. However, these successes have so far been uneven, with 1/3 of girls in high-income countries now having received the full vaccine course, yet less than 3% of girls in poorer countries are protected. These are the countries in greatest need. Gavi, the Global Vaccine Alliance, is working to change this. 1 million girls in the poorest countries have so far been vaccinated with Gavi support, and Gavi plans to reach 30 million girls in 40 countries by 2020. Gavi's vision is backed by evidence. Recent analyses suggest that HPV vaccination is likely to be very cost-effective in almost every country in the world. These calculations are conservative, in fact, because at the time they were performed, they assumed 3-dose schedules. But more recently, WHO has supported reduced-dose HPV vaccination, which will greatly enhance both delivery feasibility and cost-effectiveness. As has been said, this is truly a transformational moment for the health of women and girls across the world. It will take time to reverse the global tide of cervical cancer because HPV vaccination is designed to protect women against cervical cancer in later life. Global predictions suggest that at current levels of coverage, we'll be able to avert 2 to 5 million cases in the next 50 years. However, a next-generation non-valent HPV vaccine is now available, which will increase protection from 70% to 90% of cervical cancers. If this vaccine can be delivered to 80% or more of the population, a coverage rate consistent with what's been achieved for HBV vaccination, the benefits will be magnified. And furthermore, if vaccination can be combined with cervical screening just a couple of times in a lifetime, consistent with the new ASCO recommendations, this will not only increase the overall gains, but will bring forward the benefit to protect the hundreds and millions of older women already exposed to HPV. By combining these interventions, we'd see substantial benefits by 2030 and avert up to 15 million cases of cervical cancer in the next 50 years. These enormous potential health gains must underpin our vision of HPV prevention. At the broadest level, it's been said that prevention must be writ large in cancer control plans if we are to defy the dark prediction of the statistics. Prevention, of course, is not the only element of cancer control, but prevention must be a focus. In the absence of successful implementation of preventative strategies, low-income countries will not have sufficient resources to effectively deal with the enormous projected demand on cancer services. The human and economic burden will be immense and unsustainable. We must work to demonstrate that preventative solutions are feasible and practical in every country, and that they deliver a return on investment which will justify governments making prevention a linchpin of health and societal planning. We're on the threshold of a new era. Literally millions of lives can be saved by actions taken today by governments and civil society in tobacco control and HPV prevention. So let's all together defy the dark predictions. Our best hope for a cancer-free future is to invest heavily in prevention. Thank you.
Thanks very much. And now, Lord Shulman from the Abramson Center.
Good afternoon, everyone. I'm not Donald Trump. This would be a more civil debate than we've seen in the US in the last few months. This is our cancer center in northern rural Rwanda, our Butaro Cancer Center of Excellence. And it's in a very rural area. It's not close to a paved road. Though 10 of my colleagues from Butaro are here with us this evening, and I want to use Butaro as an example of what I think that we can do to people around the world who are afflicted with cancer and who, in fact, should have options. So these are some quotes that I have for you. It sort of says, well, you know, the treatment of cancer is too complex, it's too dangerous, you're going to kill more people than you help if you try to administer it in places like rural Rwanda. The second quote says that that bringing free cancer drugs to places like Africa will not solve the problem. Really what you need is to develop cancer care infrastructure, which we would agree with, but cost is a major issue, and I'll come back to that later. And finally, it says that we should focus on prevention, and Karen's talked a little bit about that, because 1/3 of the cancers are preventable, and we'll come back to some of those cancers in a few minutes. But I would ask you, well, what about the other 2/3 of people who are afflicted with cancer and who have options if they lived in the US or if they lived in Paris? So I would say that prevention versus treatment is a false argument. I'm not going to argue against prevention. I think prevention is critical, and I think Karen's summarized why it is, but it should not be an either-or question. And that was the issue that was raised now about 15 years ago with HIV, when they said that treating HIV in sub-Saharan Africa was both too expensive and, in fact, people didn't have watches, they wouldn't take the medicine on time, they wouldn't be compliant, it would be a waste of resources, and we should just try to prevent HIV. And I think what we've learned in those 15 years is by both treating and preventing HIV that we've turned the tide around that people thought would never be turned around in 2001 and 2002. And I would argue would never have happened if all we did was focus on prevention and never treated those people. So this is a picture from our pediatric cancer ward at Butaro. And in case you think that this is on their way to a picnic, you can look and see that each one of these children have an IV in their arm. They're all in the cancer ward to receive chemotherapy that day. And I would ask, do we turn our backs on these children who have a potential 80% chance for cure and a long life if they were treated in places like Paris or the US, and just work on prevention? Because the diseases that these kids have, none of them are preventable. 80% potential cure rate. And I would say that if you wanted to have the biggest impact on reducing cancer mortality worldwide, that you should bring the tools that we currently have at our disposal in many places in the world, like the US and France, to those cancer patients who have no access. But that if we do this, we need to do it both effectively and safely. So this is not an easy thing to do, but I think I'm going to show you some data that even in northern rural Rwanda, we can do this, and we can do it safely and effectively. Prevention will reduce cancer incidence if it's successful, reducing tobacco use and so on in the decades to come, but we can help people and reduce mortality today by bringing these treatments to them. So what should be our vision? We should say that patients should expect accessible, high-quality cancer care for treatable and preventable cancers everywhere in the world. That the care should be affordable, and this is a big issue. That poverty should not be a barrier to care, and for many in the world, that means that the care has to be free, and we provide free cancer care at Butaro in Rwanda. And finally, we need to build in-country capacity, and this is why my colleagues are here, to show that we're already doing that, so that we develop solid care infrastructures in the countries run by the people whose countries they are. Now, this is the way we've tried to look at cancer care in Rwanda, and it's a spectrum all the way from education, both of healthcare providers like physicians and nurses and community health workers, to risk reduction, screening, early detection, diagnostics, treatment, survivorship, and palliative care. And in fact, all these components are humane things to do. Even when you can't cure a patient with cancer, you should be able to palliate their symptoms and help them in what's the most difficult part of their life. So these are the four categories that we've thought about cancers. The first is what Karen referred to, which are cancers that are amenable to what we would call risk reduction. Smoking-related cancers like lung cancer and head and neck cancer or bladder cancer, HPV vaccination for cervical cancer and head and neck cancer. And I would emphasize what Karen pointed out very well, which is that if you have a successful program for HPV vaccination, that will reduce the cervical cancer burden in a few decades. And in fact, in Rwanda, we've now vaccinated over 90% of the young girls in the country in a collaborative program with Merck. But we will continue to see high numbers of cervical cancer patients for the next several decades because of the number of women who are already infected with HPV. And though I would agree that good screening programs are available, a component of a screening program has to be a treatment program when you find cervical cancer. The second category are diseases that require surgery and often systemic therapy or radiation, like breast cancer, which is the most common disease that we see in Rwanda. And I would say breast cancer is not a terribly preventable disease. Obesity may be a risk factor, but that's not a major issue in Rwanda. In fact, malnutrition is more of an issue in Rwanda than obesity. And I would suggest that we're not going to reduce the number of breast cancer patients very much in Rwanda with any intervention. The third category are diseases that even at advanced stage can be cured with chemotherapy, things like testicular cancer, Hodgkin's lymphoma, acute lymphoblastic leukemia in children, none of which are preventable diseases, all of which are highly curable with agents that are readily available in many parts of the world. And then finally, diseases that are amenable to long-term palliation like chronic myeloid leukemia, which I'm going to come back to, Kaposi sarcoma, and metastatic breast cancer. I also want to make a comment about how to do this, and this is a little bit of an advertisement, if you will. We don't have full-time oncologists currently at our cancer center in Butaro. We have one in the audience who I'll show you a picture of later who's training to be an oncologist in Tanzania. But we do this with support from US-based oncologists because, in fact, if you look at the world's population, there won't be enough oncologists for probably 20 or 30 or maybe even 40 years from now to care for all the cancer patients in the world. So we have to develop alternative models of care. And I would say that this position has now been supported formally by the American Society of Clinical Oncology as of last month. But when you do this, you have a responsibility to measure your outcomes. So it's fine to say that you're going to treat people, but you need to do it safely and effectively. And this is a manuscript that we published in the Journal of Clinical Oncology last year that basically says implementation, science for global oncology, the imperative to evaluate the safety and efficacy of cancer care delivery. So I think there has to be a responsible part of this treatment. You can't just do it willy-nilly. Those of us who have been cancer doctors for a long time understand that profoundly. What are the benefits of implementation science? Well, we want to prove to the world, including you, and maybe we'll get some of you to change your vote, that it's feasible to administer effective chemotherapy in sites like this. First and foremost, though, we want to measure the outcomes to improve our treatments and to benefit the patients who are coming in the future. Secondly, we do want to prove to the governments, to the ministries of health, to NGOs, that cancer delivery is a possible safe and effective treatment, and we want to prove to funders that it's worthwhile supporting cancer care, just as they did with HIV 15 years ago after we were able to prove that we could effectively deliver HIV care in many settings. So this is another group of kids from our hospital in Butaro. The one on the left is a little boy named Fabrice. And Fabrice, at the time of this photo, was 4 years old. He had Wilms tumor. He received inexpensive chemotherapy and surgery. One of our colleagues who is presenting work here at this meeting has done a careful costing experiment, and our estimate is everything, including pathology, surgery, chemotherapy, inpatient care, all cost about $1,400. So you have to ask yourself whether Fabrice's life is worth $1,400. Some of us would argue that it is, and I hope the rest of you would as well. This was actually in 2012, and we checked on Fabrice a couple of weeks ago. He's now 8 years old and happily in school, and will be back in January for his follow-up appointment. So we published our experience with Wilms tumor with nephroblastoma in Rwanda, and we mapped out where everybody died and who lived, and what we found was that 59% of the children are currently disease-free. Not as good as it is in Philadelphia, at the Children's Hospital of Philadelphia, where it would be 85%, but it's a lot better than 0%, which is what it was about 5 years ago. Likewise, here's a woman with chronic myeloid leukemia who we were able to treat through the generosity of the Max Foundation and Novartis with imatinib. Imatinib has been a wonder drug for this disease, and it's in fact been a wonder drug for our patients, and we've been able to treat them because of this mechanism. And we published this last year our results of treating our first 50-some-odd patients with chronic myeloid leukemia. Again, we had a flow diagram that you can't read, but just shows you that we mapped out who did well and who didn't do well. And what we know is 95% of the patients who were treated are still alive, and 75% are in hematologic remission. Again, not as well as we would do in the US or in Paris, where there are recent articles now that suggest that with state-of-the-art treatment, which includes some second-line therapies, that the life expectancy for patients with chronic myeloid leukemia approach those of the normal population. So this is my last slide, this is Dr. Fidel, who's down here in the third row with us here today on the wards at Butaro. And on the right is Agnès Benoît, who is the Minister of Health for much of the time that I've worked there, who says linking humility and bold vision to scientific rigor is the surest route to value and equity in global health. And I think about, you know, what patients deserve in all parts of the world, regardless of where they were born, regardless of their level of poverty. What do we owe them as a humanitarian effort when we have curative therapies readily at hand that could save their lives? With that, I'll end. Thank you very much.
Thanks very much to both our speakers, and a reminder that their views expressed here are not committing their institutions in any way, or indeed actually even them personally, because we've had to force them slightly to take slightly more extreme views on either sides. But as I put it to them earlier, this is a reminder that, of course, you know, we'd like to do everything. Of course, in some ways, treatment is prevention, and the intersection of the two are fundamental. But suppose you were a policymaker and you had $10 million, $100 million incrementally to spend, how would you spend it? And just a reminder of a couple of figures, but the OECD's most recent estimates of rich countries' health expenditures was that something like below 6% of total public health expenditure went to prevention, and the vast majority went to treatment, and something like 40% of total cancer burden around the world is from preventable causes. That's on the one hand. On the other, as we've heard, of course, there's the power of the ability to tackle life-saving conditions, treat patients now with an increasing amount of success, and without the huge amount of resource that's focused on R&D, both for protocols and for new medicines and radiotherapy, of course, a lot of those advances wouldn't have been possible, and big achievements in life extension have taken place. So now it's over to you. We'd love to hear your perspectives on this. Fairly short interventions, if you can, please, to the point, and ideally really on one side or the other. Who would like to raise their hand and take part in this? Yes, please. I think have we got some mics? Ah, there we got a mic at the front there. Great. Yeah, if people might like to even come behind to make this smooth, that would be great. Don't feel shy.
My name's Terry Slevin. I'm from the Cancer Council in Western Australia, and I'll confess my bias. I've been working in prevention for 30 years. My observation is that, thank you for your presentation, it was excellent. But the observation I would make is when we're making this debate, and it's a real world debate in the allocation of health resources, we can't show the photographs of people whose cancers were prevented. We can't name Fabrice. We can't name the people who didn't get the disease. And that emotional impact of being able to name a little boy is very powerful and very effective at drawing resources for treatment. And I understand why it's used, because those who do so with very strong hearts. The prevention argument is an intellectual argument based on numbers and based on evidence, but we don't have photos of the people who don't get cancer.
Yeah, Nereo Segnan from Italy. Of course, it doesn't make any sense to challenge prevention and treatment, primary and secondary prevention with treatment. We need all of them. But I think that we have to consider that the risk of cancer, especially in low, medium income countries, is low because most of the risk factors for the moment in some places, including Rwanda, I think, are low. And so the risk of breast cancer, colorectal cancer, and other cancer related to lifestyles in these countries is still, perhaps for a short period of time, still low. So we have to maintain low, to keep low these risk factors in order to avoid the epidemic of cancer, the epidemic of obesity that is already present in many countries. So the prevention in low, medium income countries is relating to maintaining healthy lifestyles where these lifestyles are still present.
Yes, sir.
I'm Dr. Grover from Delhi, India. Well, the issues both are important, but there cannot be a sharp dividing line between the two, just for the reason, when we talk of scarce resources, that we are meaning low and middle income countries, where the facilities of cancer treatment are already very low. Like I said, in India, we have 1.4 million new cancer cases every year, and the facilities for treatment are just for about 50% of them. If we start or focus on prevention program, there is sudden awareness in the society. And many of the people who are sitting silently in the society, they'll come up for diagnosis and treatment. And you don't have the facilities. That means you diagnose a person and not able to treat will become psychologically more worse for the patient. If you remember the example from US, in 70s, there were 2 celebrities who were diagnosed with a CA breast. And suddenly the entire population of women of USA, they got aware and they started coming from mammography. And it was felt that probably there is a certain epidemic of CA breast at that time. Because many of the ladies who were sitting silently without noticing the lump could be a cancer, they were not coming for the diagnosis and treatment forward. So we have to invest on treatment simultaneously, because otherwise you'll be preventing diagnosis, but they will not be able to treat them. Any impact of prevention will be seen after maybe 10, 15, 20 years. Till then, whatever you're diagnosing, what to do with that? And secondly, even if you prevent those cancers which are preventable, does it mean that cancer will be totally eliminated or will become immortal? Only one good thing is not that prevention is not important, but prevention will be able to prevent those cancers which are preventable, like head and neck and cervical cancer, which affect a person in middle age, 30s, 40s, 50s, when they are socially important for the family, for the society, for the country. So by prevention, we'll be able to prevent those cancers, but they'll live on to 60s, 70s and come back with the cancers of that age, which probably are not preventable. So till such time, prevention, I will not like to undermine, we should strike a balance and put prevention on that kind of platform where probably you're not needing to spend much, like school health education program. Media. Proactive, like in our country, we are not able to do pap smear for a woman once in lifetime also. Even if you promote that, you don't have so many cytologists, you don't have so many cytopathologists. So we are talking of a situation which is theoretical. So, and while the treatment facilities are only for the 50% of the patients. So we have to strengthen the treatment facilities to be able to know that when after the population size, because despite the fact that All the developed countries are very well equipped with the preventive program, but the cancer incidence is about 300 per 100,000. And see the low middle income countries, developing countries, the cancer incidence is much low. It's 100 per 100,000. But as the longevity will improve, the cancer incidence life will increase there also. Lifestyle will change, the cancer incidence will increase there also. So we should focus more on prevention and early detection with those kind of modalities which do not cost much of expenditure today because the sources are scarce. We have to strengthen our treatment facilities to that level that those patients who are coming for diagnosis, we should be able to treat them. So that's something which I just wanted to make a point.
Thank you very much. Please, over there.
It's May Waha from the IEA. So basically, as we all know, prevention is less morbid, less expensive, great way to go. But what about the people who have it now? And how could we just sit by? So in addition to that, our main responsibility is to use the resources wisely. So one of the things is resource-sparing studies, for example, like that could really cut the cost down. We had a GBM study showing that we could do 1 week of radiation instead of 3. So already you have 1/3 of the cost right there. And the same with brachytherapy and various other treatments. So resource sparing is important. Early detection, because you need less treatment then, is important. So I think it doesn't have to be either or. We have to do prevention for the future, but we also have to treat the people right now, keeping in mind that we have to keep the costs low by using these resource-sparing techniques.
Thank you. I think at the front there, and then at the back.
More than an intervention, it's probably a question. You both agree from the beginning that this is a false and unfair dichotomy, and obviously you have to do both things. So my question is, if you are talking to a country with low resources, which percentage will you assign to each of both fronts of intervention? Which percentage will you propose or bargain, if can I use that expression?
Which percentage for prevention and which percentage for treatment?
Exactly.
Okay, thank you. Is there a question further back there? Yeah.
My name is Paul Rogers. I'm a pediatric adolescent oncologist with a foot both in South Africa and in Canada, and I've seen both perspectives. So from a pediatric perspective, obviously I'm for treatment because we can cure so many of them. But also as a pediatrician, I'm for prevention. Prevention starts in childhood, and we fail to recognize that frequently. And it's not only prevention of cancer, it's prevention of many other chronic diseases. And we sometimes live in our little cancer silo and don't think of the overlap of child health care and prevention of many diseases. I also like to comment on something that has been left out. You commented that maybe 1/3 of cancers are preventable. I think it's higher because you failed to mention the importance of nutrition, what we shouldn't eat and what we should eat. And the nutritional oncologists, and there's a big fat book called Nutrition Oncology, they recognize that probably at least 30% of cancers are preventable by appropriate nutrition. We know about the obesity epidemic in the first world countries and the correlation between obesity and the increased prevalence in breast cancer and colon cancer, etc. We also know that in pediatrics, nutritional status on both sides, overweight and underweight, directly affects outcomes. And there was a very good article on this in JCO last year. So nutrition plays a very important role, not only in possibly preventing cancer, helping patients through their actual treatment. Another interesting figure that comes out of Central America and also India, the highest cause of abandonment of therapy in pediatrics is the poverty and the related to the nutrition. They did an intervention in Central America and cut down that abandonment rate. A personal time when I was at Tata Memorial Hospital in India, a very philanthropic lady put in a cancer program of only nutrition support for both the children and the families in hospital and when they go home. They cut the abandonment rate from 35% to 5%. So both in treatment and in prevention, nutrition should be more placed in a higher priority than I think it's been given.
Thank you.
Katia Confortini, Wellesley College. I want to make a philosophical point, I guess, that relates also to the trade-off between prevention and treatment. Why are we talking about cost effectiveness for a right? Health is a right, or so many international documents say, so we shouldn't care about how much it costs. Or if we do, we should also think about the trade-offs that are done that we do with the choices that countries and international where we spend our money. Why, for example, how many? If we go back to what the president of the League Against Cancer, French Legion Against Cancer said, if health and cancer is related to peace, then why do we spend more money, or many countries spend more money on the military than they do on healthcare? I think that that's a real trade-off. Related then to that, if we think of instead really making a cost-benefit calculation, I think that we really need to think about non-behavioral causes of cancer and how we can prevent those. And those are related to, for example, environmental causes, or much bigger causes of cancer that are not reducible to how someone chooses to smoke or feed himself or herself. That, if you factor those causes, I think that the cost of prevention becomes a lot bigger and a lot also more political than technical.
Thank you. Please.
Françoise Meunier from UICC. I will continue on philosophy. For more than 40 years, we know the dramatic effect of tobacco. And with limited results, we try to say that we should prevent and have effective tobacco control means. We have to acknowledge that it is very limited results and more or less a failure so far, particularly when you see the young. So I think unless we have a political will, we scientists and doctors and oncologists, we can say whatever we want, we don't reach what we want to reach. For 40 years we know that. So I don't understand why the packet of cigarettes does not cost 1,000 euros. The day it costs 1,000 euros, I can assure you that there will be less smoking.
Or maybe just ban tobacco entirely. Please, there's one in the middle.
Leslie Rushton, Imperial College London. I just wanted to, two things. One, to comment on cost effectiveness, and I agree with the speaker before last, but economics rules everything. Everything, if you think, boils down to how much does it cost and how much can people afford. And that's really what you're arguing about. How much money have we got and what should we spend it on and what is cost effective? But I absolutely agree with the previous speaker but one, that health is a right. And I think that is what we need to actually focus on. But the other thing I wanted to make a plug for was Debate 3, which is at the same time, I think it's earlier, on Thursday, will look at the causes of cancer that we haven't looked at the moment here, and that is occupation and the environment, where, as the speaker before last was right in saying, many of the cancers caused by those are out of control of people, whereas a lot of the things we've been concerned about today, we have a handle on. The things that we'll be looking at are things which we don't necessarily have a handle on. So that's something else to think about when you're considering prevention versus treatment. Thank you.
Thank you very much. And actually, to continue the commercial, I believe tomorrow there's the second big debate, which is on nutrition and the role of partnering with the food industry, going back to a previous question on the role of nutrition in cancer and other health factors. Is that a question there, sir? No? Okay, so I think we're, in any case, moving into our final element. We've heard a lot about the balance of the two and the need to integrate. We've heard about the challenge of the personal face of the patient compared to the slightly more abstract case of the person who never becomes a patient through interventions. We've heard about the costs and the trade-offs and the rights. We also had a specific question on where should that actual ideal allocation be between prevention and treatment. Larry, perhaps you've got 3 minutes for some closing remarks.
Sure, thank you very much. And I think we heard some great comments from lots of people, and there were just a couple that I did want to address. Our pediatric oncology colleague from Canada and South Africa talked about nutrition, and we could not agree more. It's another part of one of my other talks, but a child who's starving is unlikely to benefit from chemotherapy or other types of cancer treatment, and nutrition is key during treatment and obviously all through their lives. And so it is a responsibility for centers like our center, and we do this, to nutritionally accompany our patients and make sure they are well nourished, not only during their treatment, but in the years to come. They have transportation, so that's not a reason for them being lost to follow-up and so on. So there is a lot that has to surround the delivery of cancer care to make it work. The other thing that I do want to mention, and it's just putting it in this light, and Andrew just sort of referred to this, is there's that theoretical person who you never can identify, whose cancer was prevented because they didn't ever start to smoke or they stopped when they were 18 years old after having smoked as a teenager. But for those of us who provide cancer care, sitting in a room with a patient who you know we have the tools to cure that person, to give them a normal life, the 35-year-old mother with breast cancer with 3 children, to turn your back on her and say, you know, this is where you were born, you know, you don't have any access to this treatment and you need to go home and die. I don't think that's a humanitarian tenable argument. It goes back to one of our colleagues who said, you know, what is a human right? When you have the tools to cure somebody, whether it's tuberculosis or malaria or another cancer, and we don't deliver that curative therapy to a human being, what is that saying about us as a people?
Thanks very much. Karen.
Thank you. Well, I think we all agree that it is a false dichotomy we've been trying to talk to for the sake of trying to have a debate about this, but actually we've all ended up in the same place, that really we need to be thinking about packages of investments. And I come back to what the World Bank has put out there because I really think it's a good starting point across the spectrum of cancer control. I think the thing about the package that they've proposed is that it provides recommendations that are proven and effective and have worked, at least in high-income settings and in some middle-income settings. And so those interventions are control interventions across the spectrum. It's not a case of either or with prevention versus treatment, because some prevention strategies are not yet proven effective or cost-effective in certain settings, as is the case for treatment. So I think we have to kind of take a very nuanced, balanced view of this. I think the other point that I'd like to raise is that, you know, countries in the end will need to make these decisions for themselves, and our recommendations can only be a starting point, or these kinds of exercises can only be a starting point. And really, one of the things that's really striking is the dearth of evaluations of the cost effectiveness of any types of cancer interventions from low and middle income countries. And I think we really need to focus on developing that in-country capacity and ability to do this kind of economic analysis and this kind of trade-off analysis. We agree that it's a moral right to health, but the reality, the pragmatic reality, is that budgets, at least in this era, are very constrained in all settings. And so cost effectiveness is just a tool and it's just a starting point, but I think it really is a useful starting point because the essence of it is, it tells us for each dollar we spend, how many lives we'll save. That's what it boils down to. So it gives us a metric that tells us how many lives we'll save across the spectrum of cancer control. That's why it's a useful starting point. Thank you.
So we're now going to move back to your second vote. So please, back to your smartphones. And a reminder, the survey button, the question will be back there again. So where to spend scarce resources, should they be on prevention or treatment. Do please now vote. And meanwhile, perhaps just for both of you to go back to that one question. I mean, Larry, we don't really know the numbers even, but if we assumed it was something like 6% today on prevention, even in richer countries, where would you like to see that split? How could that balance be?
Well, so how you divide your money up, I think, we could play on some of the points that were made. You're assuming in this argument that there's a fixed amount of money for health care, as opposed to military spending or other aspects of government spending. And that could be reevaluated as well. One of our commentators made that point, how many kids could you cure or adults could you cure with, the money you spend on one tank? And the answer is actually quite a few. So there are ways to look at it. The prevention story is different in different countries. There are countries that have very low incidence of smoking and very low incidence of obesity, where nutrition actually may be the major issue. It's underweight, not overweight. You have other countries where smoking or betel nut use is very high. But the other thing I would say is, as you work towards putting money into prevention, you don't really know what the outcome is. You can put a lot of money into an anti-smoking campaign, and you're not going to get everybody to stop smoking. There's not been a situation anywhere in the world where that's been accomplished. So the gains are incremental, and that's really how you have to figure out where you're going, not make the assumption that if you had an anti-smoking campaign, everybody would stop, because I think that's naive. You could charge €1,000 for a pack of cigarettes, and that might help, and I wonder why they don't do that. But there are different ways to analyze the finances. And I do think that countries have shown that, in fact, they can do both if they're thoughtful about how they spend their money on both sides of the equation.
Okay, thanks for that. Do keep voting, please, if you haven't. And Karen, just any come back on that. Do you think the 6%, let's say, should be higher?
Well, I'd like to pick up, Larry, on that point about tobacco control. I mean, success is relative, right? I mean, the epidemic's matured in high-income countries. It's recently been estimated that I think 8 million lives were saved in the US by the tobacco control interventions that have been instigated since the 60s. So that's enormous. Yes, there was about twice that many lives taken, but 8 million lives is not to be sneezed at. And so I think that, yes, it's incremental. But the point, again, is that the incremental benefits from a couple of % reduction in smoking prevalence are just enormous.
Okay, thanks very much. Can we see the results, please, so far? How are we doing? Oh,
I made some progress.
There's quite a significant shift there. But I think at the same time we can say our speakers have both come to something of a compromise in terms of the trade-offs between the two extremes and how they need to be integrated. And I think also the point about the danger of a cancer silo at the expense potentially of other diseases and the importance of integration with NCDs, as we've seen at this conference, and other diseases is of course fundamental too. So a great debate. Thank you for your participation. Do please thank our speakers.